So in this lecture we will study about the fibrous dysplasia, which was firstly recognized by Lichtenstein and Jeffrey in the year 1942. So what is fibrous dysplasia? It is a developmental tumor-like condition of bone. It is a fibro-osseous lesion. So what is fibro-osseous lesion? Where occurs a replacement of normal bone by fibrous tissue. Now in the fibrous tissue there is a formation of mineralized product that increases with that of the time. This is a fibro-osseous lesion. Before coming to the etiopathogenesis, I would like to have some normal concept or the normal physiology. In our body we have the NAS1 gene that stands for guanine nucleotide binding protein and alpha stimulating peptide. Note that alpha stimulating peptide. So its function is to control the alpha subunit. Normal function is to control the alpha subunit. So what is alpha subunit? Come to the GPCR. G protein couple receptor. Here we have the G protein. So it has the three subunits, alpha, beta and gamma. Normally what happens, alpha unit when binds to the GTP, it remains in the active state. Now it is stimulating in nature, it stimulates a various type of cells. Now when there comes the GTPase, it converts the GTP to GDP. Now it becomes inactive. So this was a normal physiology. Now what happens in the fibrous dysplasia? There is mutation in the NAS1 gene. So mutation basically causes an intrinsic loss of GTPase activity. So there is a defect in inhibition of G protein. Basically the alpha subunit which was stimulating in nature. Now you got that how in the fibrous dysplasia there occurs a proliferation of various types of cells, because now we have the activation of adenyl cyclase that causes a prolonged activation of CAMP that acts as second messenger. So there occurs a proliferation of various types of cells like osteoblasts. Osteoblasts are the bone forming cells. There is an immature bone formation, and feedback mechanism causes the activation of interleukin 6, which is a cytokine. So there occurs a fibrous dysplasia. If there is a proliferation of melanocytes, there is a pigmentation. Now we call it as a cafe-olate lesions. Now if there is a proliferation of endocrine cells, we have the endocrinopathy like hypothyroidism, hypoparathyroidism, hypercortism, precoccus puberty, and increase in the growth hormone. Now types of fibrous dysplasia: polyostotic and the monostotic. If there is a mutation in NAS1 gene, mutation occurs prenatally or it may occur in the postnatally. So prenatal mutation can occur in the early pregnancy and in the late pregnancy as well. So if the mutation occurs in the early pregnancy, now we know that the primordia is condensed. There is a mutation in the pluripotent stem cells. Many bones are affected, which we called it as a polyostotic type. So late pregnancy and postnatally there is a formation of the monostotic type, or like single bone is affected by the fibrous dysplasia. Now coming to the clinical feature, monostotic type is more common in the second to third decade. It is more common than the polyostotic type as well. And the chief complaint of the patient is painless enlargement of jaws in case of the oral cavity. So it is basically unilateral. So commonly affected sites: craniofacial bones, ribs, tibia and femur. So what is craniofacial fibrous dysplasia? So coming to the jaws firstly, maxilla is more commonly affected than mandible by fibrous dysplasia. Okay, so if there occurs a mandible involvement, it is truly monoosteotic because only mandible bone is affected. In case of maxilla, there is an enlargement of the maxilla and there is a formation of like leonine like faces or lion like faces. Okay, you can see it in the picture. So because why I call that it is not truly monostotic when there is involvement of maxilla, because if maxilla affected, other bones of the face are also affected, like that of ethmoid bone and sphenoid bone. So better we use the term craniofacial fibrous dysplasia. So it is also called as a leontesis ossia. That means the lion-like face. So it is seen in craniofacial fibrous dysplasia, also seen in Paget's disease, and thirdly, it is seen in lepromatous leprosy. Now, polyostotic type. It is more common, congenitally in nature, and before 10 years of age, 60% cases appear, and females more commonly affected than males. Chief complaint is bone pain and spontaneous fracture. Now we have the two subtypes of the polyostotic fibrous dysplasia. One is McCune-Albright syndrome, McCune-Albright type, and second one is Jaffe-Leichenstein type. We will study the difference between two further. So if fibrous dysplasia affecting femur, we know that femur is the weight bearing bone of our body. We all know that. Okay, so what happens? There is a bending of the proximal end of the femur, like that of the Shepherd's crook. So we call this as a Shepherd's crook deformity. You can see in the picture. And the second, it like appears like that of the hockey stick. So we also called it as a hockey stick deformity. And the third one, very important, coxa vara. There is involvement of hip. There is a bending of the femur, proximal end, because it is immature, and there is a weight. It is a weight bearing bone of body. So now my favorite syndromes associated with polyostotic fibrous dysplasia. First is McCune-Albright syndrome. Second, we study that Jaffe-Leichenstein type or Jaffe-Leichenstein syndrome. Thirdly, Maza-Brod syndrome. Maza-Brod syndrome. So what is Maza-Brod syndrome? It contains two things. Like first is the intramuscular myxoma, having the polyostotic fibrous dysplasia. Mostly there is polyostotic fibrous dysplasia, but sometimes there may be the monoostotic in the Maza-Brod syndrome along with the intramuscular myxoma. So in the McCune-Albright and the Jaffe-Leichenstein type, we have the multiple bones affected, and there is a presence of Café-Uleth lesions. And thirdly, there is a presence of endocrinopathies. But endocrinopathies are not seen Jaffe-Leichenstein type. It is only seen in the McCune-Albright syndrome. This is the difference. This is the main difference. Okay. So what is Café-Uleth lesions? We have a French term. In the French, café means the coffee, and late we called it as a milk. So Café-Uleth means coffee with milk appearance. You can see in the picture. And you can see like fibrous dysplasia unilaterally and Café-Uleth lesions unilaterally and having the irregular borders. These are well appreciated in the pictures. The Café-Uleth lesions, it is appearing darker than that of the surrounding or the normal skin. So these are the Café-Uleth lesions. So in the second picture, you can see that there is a Café-Uleth spot but having the regular margins. So it is also seen in the neurofibromatosis. And in the first one, we have the fibrous dysplasia, the irregular borders. In the neurofibromatosis, there is a regular borders or the regular margins like that of the, see in the map, like that of the coastline of California. So we called it as a coastline of California. And in the fibrous dysplasia, we have the irregular margins of these spots like that of the coastline of Maine. So now you got the difference between these two, and the fibrous dysplasia occur the ipsilateral, and Scaffold lesions are also seen in the Peutz-Jeghers syndrome. Here we also have the intestinal polyposis syndrome. So radiography. Initially there is a radiolucency seen. So in this phase we have a Rin sign. Rin sign is positive. What is Rin sign? Now in the X-ray you can see like there is a isolated radiolucent lesion which is surrounded by a well-defined sclerotic border. Isolated radiolucency surrounded by a well-defined sclerotic border. It is, Rin sign. In the mixed phase, we see the ground glass appearance. Now in the picture you can see that ground glass, it is like hazy in appearance, and normal is, crystal clear. And second, orange peel appearance. Ground glass appearance is also seen in hyperparathyroidism also, other than fibrous dysplasia. So pudgy orange appearance, also called as pudgy orange appearance. And third is we have thumbprint impression. It is seen in IOPA of the jaws. Now you can see the ground glass appearance, hazy arrangement of trabeculae. So that gives the ground glass appearance. In the second one, there is a fibrous dysplasia of mandible, and you can see the buccolingual expansion unilaterally. Fibrous dysplasia occurs unilaterally. In this one, you can see the orange peel appearance, hazy type of appearance, and clinically you can see the unilateral enlargement of the maxilla. And the arrangement of bony trabeculae. Trabeculae are normally in the step ladder pattern, but in the fibrous dysplasia we have the small irregularly arranged trabeculae. It blends with that of the normal bones. So we use a term called as a blending borders of fibrous dysplasia. Now, if fibrous dysplasia involves the mandible, it will always occur below the inferior alveolar canal. If it occurs in the mandible. So histopathology, very important. Now you can see there are small trabeculae, small irregularly arranged trabeculae of woven bone. Now we know that woven bone is an immature bone. Now you can see that it resembles like that of the Chinese letter. We called it as a Chinese letter pattern. Now you can see how the Chinese letters look like. So we called it as a Chinese letter pattern. That means curvy linear type. Now we can see that there is absence of osteoblastic rimming. You can't see the osteoblast surrounding the trabeculae. So very important point, the osteoblastic rimming is absent in fibrous dysplasia. Okay, so woven bone in fibrous trauma and osteoblastic rimming is absent, and we called it as an alphabet soup of Chinese script writing. Now you can see that this is a fibrous dysplasia of mature type of fibrous dysplasia. We have the parallel arrangement of the trabeculae or the lamellar maturation of bone. We called it as tongues of woven bone. Okay, so remember the term tongues of woven bone. In the first one, you can clearly appreciate the spaces. We called it as a peritrabecular clefting. And we have to see that what is peritrabecular clefting. So peri stands for the surrounding and trabecular for trabeculae. Okay, clefting for space. So it is an artifactual retraction of the stroma of the fibrous stroma from the bony trabeculae. So in the histopathology of fibrous dysplasia, we can also see the giant cells, which are the osteoclastic like, and we can also see the hemosiderin pigment, and this Chinese letter pattern is also seen in the cemento-ossifying fibroma. So note the histopathological picture in which we have the Chinese script writing absent of osteoblastic rimming, giant cells are present, and differential diagnosis. We have to write the differential diagnosis clinically as well as radiographic and the histopathology and clinically. So clinical differential diagnosis of fibrous dysplasia. First is facial hemi hypertrophy, and second we have neurofibromatosis. In the radiographic and histopathology, we have the giant cell tumor, fractured calyx, aneurysmal bone cyst, non-ossifying fibroma, and sometimes hyperparathyroidism also, and low-grade osteosarcoma. Okay, hyperparathyroidism. Now coming to the treatment, we have the conservative treatment. Some cases like where there is aesthetic problems, we need the cosmetic surgery. So, but the bone reliefs, like in the polyostotic type, we can give the certain drugs. IV we have pamidronate drugs IV, and for orally we have the alendronate drug. Now we can't give the radiotherapy to the patient of fibrous dysplasia. It is contraindicated because it increases the risk of post-radiation sarcoma. So okay, remember that. Now the complications of fibrous dysplasia, very easy. Fibrosarcoma, because fibrous dysplasia contains a fibrous component, and chondrosarcoma and osteosarcoma. Chondrosarcoma because some bones mature by the endochondral ossification. Now I would like you to give a pro tip. Okay, so read that, and thank you. Happy study.